Good morning. Hope you all are doing well. Thank you very much, Dr. Talat and Professor Khwaja Zeen, for your kind invitation for me to present in this conference. It is a great pleasure to be here with you all, especially I immensely enjoyed it last year and I hope I'll do it this year as well. So today I'm going to have a talk about the correlation of low intra-abdominal pressure with inflammatory response in laparoscopic colorectal surgery. This study was conducted by our colorectal team in Luton. I have no disclosures. Before going towards my study and what we have done in Luton, I would like to reflect on how the laparoscopy evolved and how it has changed the face of the science. One of our pioneers was George Canning. He was a German scientist, surgeon basically. What he was doing was he was working on his work of gastrointestinal bleeding and finding ways how he can stop the bleeding. So he, along with his professor, Pfizer, so they both used a rigid endoscopy to look into the gastrointestinal tract. But then he used this endoscope to create a non-surgical treatment for high pressure insufflation of air into the abdominal cavity, which he termed it as left-toe tamponade. So the main theme he wanted was finding ways how to stop the gastrointestinal bleeding. So he wanted to see if insufflating air into the abdominal cavity will stop the bleeding. At that time around, most the endoscopists, the surgeons, they used the pressure around 50 millimercury. So when he was observing this effect of insufflation, so he stated that, I asked myself, how do the organ reacts to the introduction of air? And to find that out, he devised this method in which he inserted the endoscope into the peritoneum, and it is basically a cystoscopy. He performed this procedure in live dogs, and numerous of them, insufflating air, and he insufflated the air till the pressure of 100 microgram, which is quite remarkable nowadays because the anesthetic will be quite concerned if the pressure goes high. But then within the dogs, when two of his dogs died, but he stated that the others which were alive, he stated that the dogs are as alive as they can be. But later on, he left this work and went to other ways of finding ways of stopping the gastrointestinal bleeding. So that's how the endoscopic started. Similarly, at the same time, Christian Jacobius, he was a Swedish internist. At that time, the internist and the surgeons, they both worked together. So there was no hierarchy of which field goes to whom. So they both were working. So he was working in Sweden and he was looking, his work was with the tuberculosis basically. So he was finding ways how to treat the tuberculosis. So he basically coined the term laparoscopy, where he inserted his endoscope into the abdominal cavity, where he drained the ascites and then he insufflated air into the abdominal cavity. What he mentioned in his work when it was presented in France and in Germany and in Sweden, that insufflating air into the pneumoperitoneum, basically, he found that the patient's symptoms improved. So what he later on realized that while it was quite easy to create air pneumoperitoneum in patients who had ascites, but he mentioned that we should be very careful in patients where two of his patients did not have ascites, and there is high risk that these patients may have gastrointestinal injury. As the history continues, the gynecologists were the first clinicians who who worked on the laparoscopy, and they introduced this into the field of science, which was later on taken by the surgeons. So Zollikofer was the first to introduce carbon dioxide instead of air into the abdominal cavity and creating a pneumoperitoneum, while Carl Fergus was the first who used cautery to do adenolysis. 3 years later, Bosch was the first gynecologist, German, who performed the laparoscopic sterilization. Later on, Roald Palmer, he tweaked the technique a bit, saying that changing the position of the patient into Trendelenburg position improves the surgical field and a better viewing. So in addition to that, he emphasized that keeping the patient with the intra-abdominal pressure of less than 25 millimercury is important. As we all know that these clinicians were criticized over the years, and some of them aborted the procedures, while Kurt Sem, who was a very enthusiastic surgeon, and he wanted to refine the laparoscopy, and he found that inventing the instrument rather than looking direct visualization, he invented the instrument, and it's safer for them to perform the surgery. So in 1983, with his instruments, he performed the laparoscopic appendicectomy. While later on, the French surgeon Philippe Moret, he performed the first laparoscopic cholecystectomy in 1987. But before that, Much was the first person in 1985 who performed the laparoscopic cholecystectomy, but his work went unrecognized, which was later recognized in SAIDS in later years. As the discovery of the laparoscopic and the refinement of the laparoscopic and evolving, so we are finding ways where we can refine our techniques of laparoscopy, and in addition that we have a surgical field, a safer surgical field, and to visualize and better patient outcomes and recovery. So Russell, he published that he was the first to create pneumoperitoneum with carbon dioxide with a pressure around 15 millimeters of mercury. What he found was, when he performed the procedure on the biliary tract, he found that the morbidities was much lesser, and the patients recovered remarkably with a shorter period of time. And he commented that since the open surgery is going to be forgone in later years, which we all can see that laparoscopic is in its peak. So as we were refining the pneumoperitoneum, finding ways how we can improve and improve the patient's outcomes. So more studies have been done and looked into. So Ali Jan was the person who looked into the abdominal wall, whether lifting the abdominal wall will have an effect on the organs while maintaining a pneumoperitoneum. So he found that while during the early phase of pneumoperitoneum, the cardiac output reduces and pushes the diaphragm upwards. The pneumoperitoneum basically pushes the diaphragm upwards, which decreases the pulmonary compliance. Furthermore, when Galizia, he studied on the hemodynamic and pulmonary changes while insufflating carbon dioxide and maintaining a pneumoperitoneum, he found that there is an increase in peak pressures, especially in airways, and there is an increase in systemic and pulmonary vascular resistance. Similarly, Igawa, when he compared the intraperitoneal carbon dioxide insufflation with abdominal wall lift and see if there is what happens to the cardiopulmonary response, and he found that while insufflating the carbon dioxide into the peritoneum, it predisposes to cardiac arrhythmias, and he commented that patients with cardiopulmonary pathologies may not tolerate this procedure. As it evolves, again, Henny was another one who looked into the pitfalls of anesthesia and pneumoperitoneum, or whether it has an effect on the positioning. He found that the carbon dioxide, which is absorbed, it increases and it causes hypercapnia and acidosis. So then he found that if we hyperventilate these patients, we can prevent from acidosis. In addition, he found that the venous return was increased in patients because of the compression of the splenic vasculature. As it keeps on going, we are still in evolving and refining phase and how this effects of pneumoperitoneum on the organ system with the increase in pressure, and we are finding ways how we can decrease these pressures and the perioperative morbidities and increase the patient's recovery time. So Denise, he studied if we use the low pressure in the pneumoperitoneum, will it have an effect? And he assessed the quality and found that overall results were moderate to low. He found that if we maintain a low pneumoperitoneum pressure, we found the injury on the liver and kidney is much lesser. However, in addition to that, he found that the pain score postoperatively was much reduced in patients who had low intra-abdominal pressures. But he could not comment whether the quality of the surgery, surgical condition, or the safety is established. So that needs more work, whether it can be established or not, that the patients are safe. So Gransby, he published an article in Cochrane where he looked into the low pressures versus standard pressures and reviewed them. So 90% of their patients underwent low intra-abdominal pressures, and he found that there was no convincing evidence supporting that the use of low intra-abdominal pressures of pneumoperitoneum will affect the low anesthetic risk. However, he established that low intra-abdominal pressure is safe and is recommended, although he recommend that more work needs to be done whether these low intra-abdominal pressures are safe on patients who have cardiopulmonary pathologies. Moreover, Saeed, he basically did a double-blinded randomized control trials on the systemic stress response to see if it has an effect on the organs, on the responses. So he did not find any significant differences in the systemic response. And in addition, he looked into the perioperative phases where he did not find any significant differences in the intraoperative IV fluids or the urine output. But he compared the inflammatory response at early phases with the CRP at 6 hours and on the first postoperative period. Later on, in 2016, Mario basically looked into the pressures of low intra-abdominal pressures and the standard ones. So he basically tweaked the low intra-abdominal pressure and went as low as 6 millimeters of mercury. And he found that indeed there is a difference in this response. And patients with low intra-abdominal pressure has lesser systemic inflammatory response as compared to the standard, and his patients recovered remarkably. So now the question arises whether the low intra-abdominal pressure has a room in the colorectal surgery and its resections, given the fact that colorectal surgery is a technical challenging procedure itself, and given that it has longer operation time and maintaining a work balance in the pelvis, it's quite technically challenging itself, and maintaining a workspace between the abdominal wall and the pelvis and the surgical field. We need to see whether does it improve the postoperative recovery time, as the patients, especially the cancer patients, if they recover early, they can go and have their oncological treatment in a timely fashion without any delays. Does it have any effect on the inflammatory response, where the patients have low inflammatory response and the patient can be discharged early and safely? So to have a question to answer all of these questions, we conducted a study to analyze the correlation between the low intra-abdominal pressures and the inflammatory response in colorectal surgery and its potential possible impacts on early recovery and reduced hospital stay. So the methods that we did was, it was a retrospective observational study for prospective database, maintained database. So we had 4 laparoscopic colorectal resections in our department, and which 2 of them maintained pressures below 12, that is at 8 and 10, while 2 of them maintained the pressures between 12 and 15 as the standard. So we looked at their work, and we divided the group into 2, that is group A, which is the low intra-abdominal pressure, and group B, which is the standard pressure. So this data was collected in our colorectal department database. The study period was taken as 1 year, that is from this January to December 2020. All patients who underwent laparoscopic colorectal resections were included, irrespective of the gender and nature of the pathology. All patients, irrespective of the comorbidities, were included. Patients excluded were open surgery, conversion to open, and emergency surgery. The demographics were noted. At the perioperative phases, the patient had regional nerve block along with the general anesthesia, as it is our standard in our trust to have a spinal or epidural analgesia along with the general surgery and art line in place. For all colorectal resections, cardiovascular outcome and renal responses were monitored. Operation time, serial C-reactive proteins was used as a marker of inflammation and monitored postoperatively. Length of stay and recovery time was noted down, and the complication rates, that is intraoperatively while they're performing and postoperatively, were noted down. So all of these patients underwent ERAS protocol pathway, as we have a dedicated ERAS team who look after these elective patients, and then they follow up subsequently on throughout their journey. So all of these patients underwent them, and the data was analyzed using Excel sheet. Qualitative and quantitative variables were analyzed using median, mean, standard deviation, percentage, and frequency as appropriate. A total of 86 patients were identified in 12 months' time. The mean age was 66 years. In group A, there were 44 patients, and in group B, there was 42 patients. The demographics were noted, in which there were 40 patients who were male and 46 were female. The BMI, the mean BMI was 28, and there were 61 patients who had cancer lesions. So, and 25 were who had inflammatory bowel disease, diverticulitis, and volvulus, and underwent those surgery. So the type of operation also was quite variable, and you know how the lengthy that can be. So there were 7 patients who had APER. Pan-protocolectomy was done in 2 patients. There were 23 patients who had anterior resection or TATME, where 2 surgeons performed the procedure. Hartmann procedures were performed in 4 patients. 2 patients underwent subtotal colectomy. 3 patients underwent left hemicolectomy, and 38 patients underwent right hemicolectomy. So when we looked into the perioperative cardiovascular response, we looked at the patients when there was initiating the pneumoperitoneum in the middle of the procedure and at the end of the procedure to see how the heart rate was responding and how the blood pressures was responding. What we found out that the heart rate was decreased in patients who had a less than 12 low intra-abdominal pressure, and the blood pressure was maintained and was also maintained in patients who had low intra-abdominal pressure as comparatively to the high standard intra-abdominal pressures. Similarly, in the renal responses, we had a look and see how many patients get IV fluids, and they both were similar in both the group, got the same number of IV fluids, and they didn't need any furthermore. What we found that the urine output was had a significant difference in which they both were above the normal levels of ml per hour, but it was better in patient who had low intra-abdominal pressure as comparatively to the patient who had standard. Although the operation time was a bit longer in patients who had low intra-abdominal pressure as comparatively to the high, which is understanding that and the workspace that we work, it's all reduced. So post-operatively, we looked into the inflammatory responses. We found no significant differences in the CRP on the first post-op day and on the third post-op day, although there was mild increase in third post-op day in patients who had low intra-abdominal pressure. What we found that the recovery time was increased in patients who had low intra-abdominal pressure, and the patient were discharged early as comparatively to the patients who had standard intra-abdominal pressures. There were no intraoperative complications, which is quite remarkable given the fact that they worked in low intra-abdominal pressure. We found one patient post-operatively had an anastomotic leak. The patient had low anterior resection, and patient who had low intra-abdominal pressures, which was taken back to the theaters. As we can all see that science is evolving, we are trying to improve as there is room for improvement, and it is recommended to have an acceptable workspace during the laparoscopic surgery. It is a common practice to use a fixed, usually a higher intra-abdominal pressure to create the workspace. But in addition, the frequently set time is between 12 to 15 millimercury or even higher in individuals, surgeons whose preference because of the workspace, the patient's demographic, or the nature of the pathology makes it technically challenging. As in literature, we found that the increase in intra-abdominal pressure causes inflammation and injury to the peritoneal mesothelium, which in turn activates the cytokines and chemokines and increases and triggers the systemic stress response. It is found that low intra-abdominal pressure leads to decrease in post-operative pain in terms the patient recovers early and are discharged early comparatively to the standard ones. Interestingly, while I was making these slides, I've come across this recent studies which has been published, and Diaz basically looked into the individualized versus standard pneumoperitoneal pressure. When he terms that individualized, he means like the surgeon starts from 8 till 9 to 10 to 11, depending on the workspace, and then he comes back to the setbacks when he have enough space to manipulate his instruments and the surgical field. So he basically looked at the various factors involved in the maintaining the pneumoperitoneum to see whether they can have an effect on the stress response and the recovery time. So he looked at the patient's positioning, the deep neuromuscular blockade, the intraoperative ventilation with the tidal volume, the pre-stretching of the abdominal wall, as it improves the relationship with the intra-abdominal pressure and the intra-abdominal volume. So in his randomized trial, a total of 166 patients were taken, and this patient underwent laparoscopic colorectal surgery. So what he found out that in individualized pneumoperitoneum, he found that they were the recovery time was much faster, and there were fewer complications and lesser inflammation as compared to the standard pneumoperitoneum strategy. But there is something that he found that indeed the inflammation was lesser, but when he sub-analyzed it and found that the CRP did not make any significant difference, but it was the neutrophil and lymphocyte ratios in the individualized pneumoperitoneum were much lower as comparatively to the standard ones. As the science is evolving, we are finding our ways in to find better technique and patient's outcome. So there is this trial ongoing in which they're looking again at the low and normal pressure, but this time they want to see whether the colorectal surgery, what is the early quality of recovery time in perioperative care. So they have basically set the standard as Diaz, which did not set the standards of low abdominal pressures, and it was individualized basis. So in this trial, they are setting the standard as low intra-abdominal pressure, which means like it's 8 and it's fixed, while the standard is 12, to see how the recovery time is and whether the patient's improving. So in conclusion of our study, what we found was that in the low intra-abdominal pressures in laparoscopic resections has no significant differences in inflammatory response, especially because we looked at the CRP in the postoperative period, and there was no differences in the early recovery or decrease in length of stay as compared to the standard. I would say that I would blame that all due to the robust enhanced recovery team who follows the patient till the end of their journey. But we found that the patient went home earlier in those group A. However, we can say for certainly that there is an impact on the perioperative cardiovascular and renal response, and it is safe to perform in low pressures than standard. Thank you for your patience. I will welcome questions.